start with a little brief introduction and then I'll hand it over to you all. Hi everyone, thank you all for joining and thank you Dr. Chittalia and Ms. Finn for joining us and presenting today. Um, Dr. Chittalia is an internist and informaticist at Geisinger since 2007 after his tenure as Chief of Medicine at Berwick Hospital. He has contributed to DI initiatives and optimization of the EPIC EHR. He's an educator, speaker, and published author focused on inclusive care and innovation. He served on multiple system-wide committees, Health Intent Steering Committee, Care Redesign, Medical Home Leadership, Patient Experience, Delta Innovations, Preventive Services Task Force, Mobile Health Steering, and Educators Academy. In recognition of his equity work, he received the Philadelphia State Diversity Council Leadership Award in 2019 and represents Geisinger on the Hospital Association of Pennsylvania's board to reduce racial and ethnic disparities. From 2019 to 2024, he also served on EPIC's Primary Care Advisory Board. He advocates for health equity nationally, conducting webinars for HSS and leading international health initiatives, including founding a multi-specialty clinic in Tanzania in 2019. Mrs. Finn is a healthcare informatics leader with over 4 decades of experience driving innovation and implementing enterprise software solutions across healthcare settings in the United States and Canada. She has managed a large-scale EHR implementations, optimization initiatives, and patient experience programs to improve clinician workflows, quality care, and physician-patient experience. She currently serves as Director of Provider Informatics at Geisinger, leading a strategic program of 40-plus clinicians supporting enterprise informatics initiatives. Since 2019, she has led strategic initiatives to advance health equity through the development of inclusive clinical workflows. Thank you all again for being here, and I'll pass the floor to you all.
First, now my
Good
screen is.
afternoon, everyone.
There we go.
Thank you all for joining us, and thanks a lot for the lovely introduction. I'm going to lay the background actually for this talk. We have unfortunately, no disclosure, the financial disclosures to my. So again, I've been at Geisinger, this is my 19th year, and it's an innovative, vertically integrated healthcare system, and I love being part of the inclusive care and the health equity movement that we have created and be part of. But before we get into this presentation, I just wanted to level set about things related to health equity. So in the realm of healthcare, acknowledging and addressing the social drivers of health is not merely an option. It is an imperative that we go and do beyond that. So beyond the confines of clinical settings and medical interventions, the fabric of health is woven into social, economic, and environmental conditions which we all live in. To truly fulfill this mandate of promoting well-being and preventing illness, healthcare organizations must widen their lens to encompass broader factors shaping our patients' lives. It should not be merely aspirational, it has to be in practice. So health is not solely dictated by a person's access to care services, also profoundly influenced by their socioeconomic status, educational attainment, employment conditions, housing stability, and the overall quality of the living environment. These are the social drivers and often existing beyond direct purview of healthcare professionals, but significantly impact individuals' susceptibility to diseases, their ability to manage chronic conditions, and their overall life expectancy. This is an important statement that I'm going to make, that it should not be surprising to note that the zip code we live in may matter more than our genetic code. In focusing on social drivers of health, healthcare organizations like ours transcend the traditional boundaries of medical care. We recognize that a prescription pad or a surgical procedure is insufficient to create enduring health outcomes. By delving into socioeconomic landscape, organizations can tailor interventions that not only treat diseases, but also address the root causes perpetuating health disparities. So, moreover, this approach aligns with the principles of equity and justice in healthcare, and it acknowledges that individuals do not start on equal footing, and systemic factors contribute to health disparities amongst various demographic groups. By understanding and mitigating these drivers, healthcare organizations can actually contribute to dismantling the barriers that hinder equitable healthcare outcomes. We are in the process of becoming a primary care center of excellence, and health equity is one of our big focus. The financial implications should not be overlooked either, right? Preventing illnesses and improving overall health through a focus on social drivers can lead to cost savings for healthcare systems in the long run. By investing in upstream interventions, educational programs, community resources, and social support structures, organizations can potentially reduce the downstream burden of treating advanced diseases and managing chronic conditions. So, in essence, healthcare organization committed to addressing social drivers of health is one that recognizes health as a holistic concept, intricately interwoven within the fabric of our society. By extending beyond our clinic walls and engaging with the social drivers shaping well-being, such as systems become architects of a healthier future, a future where healthcare is not just a reactive response to illness, but a proactive force for cultivating robust, resilient communities. So I did touch upon several aspects of creating a state of health equity, but let's peel this complex ideology systematically. Remember, there is limited health quality in a healthcare system where there is no health equity. So that's what I just wanted to, like lay the foundation of this work that we have. And I think as we move forward with the deck, we're going to cover a bunch of different ideas and concepts. So we're going to talk about what is health equity, what is the relationship between health equity and the social drivers of health, and what is Geisinger as a health system doing, and what is the responsibility as an integrated healthcare system in delivering this care that is inclusive of all our members. So Heather, I'm going to toss it over to you.
So first, just a quick minute or two about Geisinger. So we are in central Pennsylvania. We extend up into the Wilkes-Barre, Scranton area. So across the kind of the central section of Pennsylvania, over 10 hospitals, over 27,000 employees. But we're not just hospitals and the ambulatory care centers. We also have our own Geisinger Health Plan. We've had a health plan for over 20 years now, and we learn a lot by being a health plan and a hospital and ambulatory care center. And then in addition, we also have a medical school and school of nursing as well, and a very active research program. So it kind of all comes together to provide care in our communities. And that slide's fine. So I know we're going to be talking back and forth about the concept of what is health equity, and Dr. Chittalia did a great job of just kicking it off. We tend to, always put up the Robert Wood Johnson Foundation's definition, just to point out that when it comes to healthcare and health equity, we want to point out the fair and just opportunity. We want to remove obstacles, and we want to acknowledge that it is a combination of jobs, pay, education, housing, safe environments, and healthcare that all comes together. And so as we're working with our patients and we're developing our programs, it's really keeping in mind all of these pieces. And I know Dr. Chittalia is going to talk a lot more about what are all those pieces. So I'm going to hand it off to you to do that.
Yeah. So I'm sure you must have heard of the social drivers of health. We call it SDOH. It used to be called as social determinants of health. So we left it here so that we could actually let you know it's the same thing. And at Geisinger, we just refer SDOH based as social needs of our patients, right? So that's the ecosystem in which you live, and we are part of this with our social needs, and we carry that to our clinicians or the hospitals where we get treated. So our areas of focus to start with, we focus on food, housing, access to care, payment of care delivery, transportation, social isolation, education, employment, network, and internet, and overall safety. So that these are in general areas that we as a system focus on besides delivering clinical care. Next, please. Next slide.
Did it switch over?
So
That one? Yeah.
yeah. So why are these social drivers of health important, right? I mean, if you look at this person in the cartoon, right? Don't go on the exact percentages, but this slide, what it actually tries to tell us that when they come to see me in clinic, my direct contribution to them is no more than 20%, right? I mean, that's what the healthcare contribution is. The rest of their care, their outcomes, and how they are able to manage their care based on almost 40% that's dependent on the socioeconomic factors, the education, job status, family support system, income. Some of it is lifestyle, and literally 30% of care in general encompasses around the lifestyle of our patients: diet, exercise, alcohol use, tobacco, sexual activity, etc. The genetics may contribute another 10%, and then the rest of it is what we as physicians and clinical care delivery systems are providing. So categories may even overlap, but the idea over here to show you all is that there are many factors that impact quality of care and care outcomes, not just the care that is provided in our clinics and hospitals. A lot of different factors contribute to the overall outcomes. Next, please. So why do we care about, and what is its impact, right? So the social drivers of health, when we ask our patients, when you're asking questions about them, we need to do something about it, right? So why do clinicians need to participate in this? Because we have a connection with our patients. There is an understanding, there is a trust, and then when we screen these patients, we use community-based organizations to be able to connect them with the right resources. And not just that, if you're participating in Medicare and any other state and local and federal funds, there are some mandates that are created so that these organizations have to comply with them and partner with the local organizations in order to help our patients get to the best state of health. And then we use a lot of this data and analytics to close the loops and understand, have we closed the right amount of care gaps or not? And what else do we need to learn from our data so that we can change and impact care going forward? So it does really impact the overall type of care we provide and the outcomes that we can achieve for our patients. Next, please. So this is a very important slide, and I really like to emphasize a bit on this. See, health equity is the eventual goal, but there are these pathways that have to align to get there. The infrastructure is at the foundation, right? And then we develop so many different programs to make sure that we look into the holistically the patient as a whole. But having the programs, which actually we will talk about a bit as we go down the lecture, but having these programs by itself is not enough. You have to continuously measure them to see the impact. We work on KPIs and assess them with our analytic tools to see if it makes sense or not. And extremely important to align with in this are the policies, the laws and regulations around these systems. So some of them are mandates, some of it is systems really trying to improve health equity of their population, and we have to make sure that to get to that sort of illusionary state of health equity, could be an aspiration at this stage, but eventually to get to that distant reality of reaching that state, all these pathways have to align and work together, and otherwise it will not work. Heather.
So just kind of comment, well, what all are we trying to put together to make this happen and to realize this? We starting up at the right, we have to use our data. We have to understand our patients. We have to understand our community. We have to be able to provide a platform that allows us to connect. So that's the social needs. So we can connect our patients with our resources. Again, at the equity, at the local level, having very active providers and partners has been key to this. We have to provide community activities to get our community to come to us in addition to what we do in our clinics. Education, ongoing education. Patients, our health plan members, our providers, our communities, every resource possible has to be thought about when we're figuring what education we're going to be providing. Our network, creating the aligned network, like we were talking about, providers, health systems, is key to this, and community engagement. So bringing that all together is what makes this happen.
Yeah. It is patient-centered, basically.
What we're going to do now is go a little bit under the hood. So, we want to help you understand when you come up with this concept and there's so many pieces to the puzzle, how do you actually implement that? How do you put it together to make something happen that really is going to be effective? So that's what we're going to do the next couple of slides. We're going to start off with a little bit about our journey with sexual orientation, gender identity to support our LGBTQ community. We're going to talk a little bit about race, ethnicity, and language and our veterans. So the SOGI, our journey with for our LGBTQ plus population started back around 2018-19, where we thought, oh, it'll just be easy. We'll put in this form that allows us to collect things like gender identity and sexual orientation and journey affirmation journeys, and we'll have our front desk, ask these questions and collect the information, and off we go. Well, we put that in for our front desk to start asking questions, and about 2 weeks later, we had to pull it all out. It was a disaster. We found that you can't just add these kind of, fields into your EHR. Number one, staff wasn't comfortable asking. Our patients at the front desk are sitting there saying, well, everybody could hear when you're asking me about my gender identity and sexual orientation. I'm not going to answer up here at the front desk. I'm just not going to tell you this information. So we pulled it all out and started again and started thinking, okay, well, who should be asking these types of questions? And we'll talk a little bit more about that. As the pandemic hit, race, ethnicity, and language became very important to us. We were starting to understand, where are our patients coming from? Are they getting COVID immunizations? What's the disease rate in our communities? And where can we make a difference? Where should we be sending out our buses to provide immunizations? And when we started looking at our data was showing us that our patients were 99% white. And we're in central Pennsylvania, but that is not a real indicative of what we are. When we started looking at surveys where patients self-reported their data for things like patient satisfaction surveys, we found that indeed they were not 99% white. So we started asking around, well, why is everybody listed as white in our system? And we found, similar to the SOGI, that our staff wasn't comfortable asking these questions and our patients weren't comfortable answering when you just start pressing them with questions and don't really explain why you're asking them. And then we also added veteran history into our journey. We have had in our area, we have a significant veteran population, and we are realizing we did not know enough and we weren't really providing care based on that history. And so what we did is we created an All About Me questionnaire, and we'll be talking about what we did with that questionnaire, how we use that data moving forward. So when we created the questionnaire, and before that, we knew that our journey was, if we're going to collect the information, we want to use it. We want to provide respectful care, quality care. We want to develop patient programs. We want to reach out to our community based on what we're learning. So, what does it take and why was it so difficult? And as leaders and as future leaders, or you are leaders now, I think it's all of these populations that you need to be thinking about whenever you're creating a program. So, we knew from our patients they were feeling judged, they didn't feel safe, privacy concerns. You have to think about things from a staff perspective. For us, we knew that staff was confused. What is gender identity? What does that mean? And why should I ask? And how do I ask? Our clinicians, education to our clinicians was equally important. Understanding medical needs, understanding how our electronic health record needs to be configured to make the documentation as simple as possible and effective. And then always taking into account the outside world, what's going on with our changing national initiatives, what's going on with standards for data exchange state by state. It's so different what could be on a driver's license and how patients describe themselves. So those were challenges as we were putting this all together. We from a SOGI perspective, there was a lot to consider as well. Our policies, we had to make changes to employee benefits policies, patient right policies, our electronic health record, we use Epic. The whole infrastructure had to be changed, workflows. Clinical decision support was huge. Now that we've started collecting this information, how are we going to use it to provide better care? And we'll talk about a few examples with that, and respectful care. Again, internal education, ton of education needed, starting with the board and all the way down to the staff on the floor. And then external education, helping our patients understand, our community understand why we're collecting information and what we're going to do with it. So these are
And you
just
know
some
what?
of the,
One
yep.
more thing, Heather, I wanted to just add something that because you guys are all informatics is that it was also crucial to understand interoperability. Like we could do what we wanted here and when in Epic, customize things and create the right fields. But if you're not able to connect and have this interoperability with other systems, where we look at our prescriptions going downstreams and things like that, because there are no set mandates, everybody was working at a different phase and then they were not really working aligned with systems who are advancing in healthcare, right? So because of that, we also have to ensure that the steps we take are not too fast paced and we are not aligning with the environment.
And some of the things that needs to be done, a traditional EHR, they had a concept of sex. So they normally had one element to collect sex, a legal sex. Well, we had to make sure we added gender identity and birth sex. So this is the sex that was originally signed at birth, which is key to providing quality care, and we'll show that in a little bit. We needed to be able to have affirmation history, organ information. That was important for clinical decision support. Pronouns so that we could provide respectful care, legal first name, the correct first and last name, and then other things you never even think about, emergency contacts, marital status, making sure that we had LGBTQ inclusive values. So a patient could have two mothers, there could be a domestic partnership, and it was not just spouse that was your only option. So changes had to be made to our base system. And then in addition, this is a little bit more about the clinical decision support and what we had to do behind the scenes and think about. So when you think about something like labs or medication, what we had to do is make sure we had logic behind the scenes so that even though my legal sex may say female, what happens if my birth organs, oh, oh, just a little echo, it sounds like. But we had to make sure that we took into account what the birth organs were so that if, for example, we were interpreting labs or we were ordering a medication or we were ordering blood products or health maintenance, you wanted to make sure that the correct health maintenance was firing based on the organs that you had at birth and may have to be able to make sure that you're not asking patients if that's something that, or ordering blood products for a patient that does not match and will cause a safety issue. and then again, respectful and affirming care when you're speaking to the patient. What's going to be on their armbands? What's going to be on electronic boards that are showing up? In a letter that they receive, what is going to be in that letter? What is their gender going to be in the letter? What does that look like? So a lot behind the scenes. So what we did is as we redid our program, this is what it looks like at Geisinger, our front desk, and on the phone. They're going to document legal first and last name, a chosen name, legal sex and pronouns, but it's only when the patient gets back to the room or is in the questionnaires that staff will start documenting further information. So we kind of drew the line saying sexual orientation, gender identity, birth sex, that's going to be clinical. And so that will be our nursing or provider staff. So for folks that,
For our Heather, one more thing I wanted to interject from an informatics perspective in delivering care, when we decided to incorporate all these fields, right? And you realize that why is it so important to ensure that the quality of care is not suffering? So we when we had transgender patients, we actually created the health maintenance for that particular age for both males and females. So if there's a transgender male, the person may still have breasts. So they need mammogram screening. So based on that age group, we turned on the health maintenance alerts for both men and women. And at that time, it was important for the physician or the advanced practitioner who sees the patient to realize what is appropriate and what is not appropriate. So then we turned off things individually that did not apply. So that we wanted to ensure that we do not miss important screening tests.
so, what does it look like under the hood for folks who have never really seen what the EHR looks like to staff? This is an example of what our scheduling registration staff uses to collect demographic on a patient. So this is where they're documenting language, veteran status, ethnicity, and race. And then this is what the SOGI smart form looks like. So some of the data may come in by questionnaire, or do you want to talk about the alert that shows up?
Yeah. So there are three fields that are related to sex. One is the sex assigned at birth, the legal sex, and the gender identity. If there's a mismatch in either of them, right, we would fire a best practice alert, or we now call it our patient practice alert at OPAs, and that would fire for the clinicians. So when my nurse rooms the patient, and then when I get to go and see the patient, I will have this best practice alert, and this is a hard stop. We hate hard stops in clinical medicine, but this is one of the important areas that we need to ensure that somebody is paying attention to that. And this BPA will allow us to understand then and bring to the forefront that hey, there's some differences in the three sex fields. Please address what is needed. So you go to the SOGI form, do the organ inventory as needed, and then ensure that the health maintenance is catered to the individual patient.
Similar to the veteran. We'll talk about that for a second too.
Yeah, so again, we wanted to ensure that we recognize our veterans. One, secondly, they have unique care needs due to their, the exposures to different toxic agents, the crazy amount of high noise frequencies, also PTSD and other kinds of trauma. So we wanted to ensure that this intersectionality of our patients get the right attention and the right clinical care that is needed. So we created a smart form for our veterans, and the smart form is assigned to them prior to the visits, and they will fill out all the relevant information. It goes into details of the wards they were in, and if there is a disability involved in it, or if they want to talk something about their history in participating in the armed services, we will fire this alert. And I'm telling you about a patient of mine. This is an anecdote. Is that I had seen a patient 3 times, and in the fourth visit, when this thing popped up in front of me on the storyboard, which will show, I had no idea that my patient was an Air Force veteran. And once I was able to understand that, we had a different level of connection, and I was able to help him and in a very, very different way. So understanding the veteran status has certain specifications or related to their care. And I will go over some of the internal data that we have collected on the veteran needs. So this veteran smart form has been very helpful and useful for us in identifying our veterans and connecting them with the right level of care that is needed.
Talk about storyboard as well, how you know as a
Yeah.
clinician.
Yeah, so this is what you call the EHR storyboard, the left column on that you see where there is a name, the web apps files is just a random name. Then there is a sex over there. That sex actually corresponds to the gender identity. And if there's an icon in between there, which you see with that means that there is a mismatch between the three sex fields, and when you click that, it opens the Soji smart form. And this storyboard area is that real estate is priceless, right? That we if you want to do anything to this storyboard, there are so many governance committees in the system that you have to actually present to justify why do you need to put this. But we did decide as a system that we must show veteran status right on the storyboard. We put the pronouns right there as well. In most of the other healthcare organization, you have to hover over it, but we wanted to ensure that it is clear, apparent, and striking. So that's where we put all these relevant information about veteran status as well as pronouns in the storyboard area.
The last couple of slides showed really what it looked like for our own clinical staff. For patients, if you've never created or filled out a questionnaire for one of your providers yet, this is what our patients see. So it's through my chart, a patient portal. You can see there what it's showing them is what data that we've collected for them. They have the opportunity to change the data. We ask these questions before patient visits, when they arrive. So we have welcome kiosks when they arrive. It may be if they haven't completed it up to that point, when they arrive at an office, we have handheld iPads that they could use to complete the information. We also do this in the exam room. So if there's other questionnaires as well, including our SDOH questionnaires, depression screenings, various screenings if you're coming in to see a specialist. What happens is when you're in the room with our nurses, the nurses can see what questionnaires you have not completed yet. They can actually flip the screen toward you, and you could complete it while you're waiting for the clinician to come in the room. And then also, if you haven't completed it, the provider themselves can bring up the questionnaires and answer it for you or with you or after the visit. So there's lots of different ways to get the information so we can pre-fill it. There's also just some plain old details about me, quick, easy ways for our patients to record the information. So what it's looked like, so we started this in August 21, where we started using our About Me questionnaires. So we've had over 481,000 questionnaires completed. On average, about 13.46% of the questionnaires are completed, which is actually right in line with all of our other questionnaires, whether it be SDOH or whatever questionnaires we have. They're about completed about 13-14% of the time. You can see most of our patients, well, 46% are doing it via my chart. When it says Epicare, that's when you're in the office, the nurse flips the screen, and that's where the next highest percentage are being completed. Some do take time at our kiosks when they come into the hospital. Secure Link is via we send you a notification on your phone to say, hey, can you complete this right now, or bedside. You can see our breakdown by sex, blue being females, about 63% are completing them, and then our age. We tried to break it out by the some age groups just to see. Now, this could also be proxies that are completing it for a loved one, but just to give you an idea. Do you want to talk a little bit about this data?
Yeah, and then we actually initially, when we started this work, it was recorded and done purely in the clinic, and our clinicians were getting annoyed that there was a lot of time that we were utilizing, but inpatient rooming. So we had to actually go and create these surveys which are assigned to patients, and actually it works better, as you know, that more majority of these this information is completed by patients on their surveys that are assigned to them. And the details about me is a different part of the chart where people can make changes anytime they want, but the surveys are assigned to them prior to the visit. And here, this is a very important slide here. This is a slide of a poster that was presented by one of our medical students in the AMA summer research. It was a competition, and he was one of the semifinalists. And this, it looks at a tool in Epic. It's called Slicer Dicer. It's basically a self tool of getting data. Most of the time you have to request to get the data out, but using Slicer Dicer, it's a self-analytic tool where you could really put in the right data model, put in the right query, get the fields you're interested, the duration, and it pulls in the data. So when you look at our own information in this area, in our practice, if we have our veterans have a lot more prevalence of chronic diseases. So if you look at the areas in general, we are COPD, hypertension, heart failure, diabetes, and cancer. The relative risk ratio is much higher than the general population. So the veterans, because of their exposure, because of the climate that they've been part of, there's a higher risk of these chronic conditions that they need special care and good amount of follow-up. So this was done in conjunction for a summer research for our medical students and presented at the AMA. And we hope to take it to a next level by creating a value-based care guide, which is going to be an interactive platform that gives a tool to our clinicians to provide good care for our veterans. So it will have a bunch of different knowledge base databases, as well as links to additional information and areas where we can connect our veterans for resources. So that's the world that we want to go into. But this is the step that we took in, and we want to build on this as we move forward.
Few
Next,
more
please.
slides. I just want to talk a little bit about some of the pros and cons. So we're using our questionnaires, and what were the results when we started using these questionnaires? What kind of feedback did we get? Well, we did get, we definitely see patients are still, some are uncomfortable answering questions. So things like gender identity, patients would put in answers like I'm offended or this is bullshit. Pronouns, same thing. They would put in, I'm a dude, or, whatever. They put in comments instead. And so, we had shown you this is again that storyboard. So, unfortunately, if somebody just puts in this is bullshit and they self-report that, well, that's what their medical record's going to show. So, we've had to take into account what patients may enter, because we do need to get that cleaned up. So is patient self-reporting the golden answer? Well, the data is definitely showing that we are collecting it. We're no longer 99% white. And so we see it as a win despite getting some of the answers like you saw before. As far as how we use it, just one slide about analytics. So what we've tried to do at Geisinger is say, because we collected it, we're going to show it in our analytics. So whenever we create reports, we always ask, our analysts, our reporting analysts, add equity filters. So add race, add ethnicity, add gender, add veteran. Oh, I've got gender twice. So that we can use that whenever we slice and dice through our data. So it's really important we do that. And I did want to give an example of what Blue Cross Blue Shield, for example, did on their site to show what their disparities look like. So we have similar programs at Geisinger where we're displaying our data as well. But I know should we switch to SDOH and then we'll take questions at the end?
Yeah.
Okay.
So the state of Pennsylvania publishes a report and talks about the social drivers of health. So the three most SDOH specific to our state is housing, poverty, and child poverty, so related to these families, and food insecurity. Next, please. So what is our strategy as a system? We work a lot on the data that we collect, very strong community engagement, and connecting resources to our patients. That's very, very crucial. And then we measure it. So understand what the outcomes and responses are. So we collect a lot of data. We have data. We have been on the EHR since the 1990s, early 90s, and we've always had Epic. And we collect a lot of survey data, we collect a lot of smart data elements, and then we analyze whatever is needed for us to be able to understand realistically how to improve care. And the community engagement piece has been very strong. It directly transcends into a med school that we have started. There is a strong community engagement program as well through that. So our students are looking as patients holistically, not just looking at clinical symptoms and diagnosis, and then understanding how to use the resources, what community-based organizations are available, and then as we get to look at the care that we provide with the areas of innovation that we have created in terms of data that we have collected, create like for improving our colonoscopy to our Spanish speaking patients. We use a navigator, Spanish language navigator, and things like that. Some basic things which actually is common sense, but it has shown to have improved outcomes for our patients. Next, please. So, as Heather had said, the SDOH is also done. One opportunity they get is a survey is assigned, and this is the time in which you assign the surveys to patient upcoming appointments, 14 days, 7 days, and 3 days prior to visits. And then if that's not done, then we will hand out an iPad at the office. Or if there are certain offices there where kiosks, they can do it over there. If that's not done, then the nurses get an alert in the grooming process to talk about the social drivers of health. That's documented. And anytime the patient wants to look at it and talk about it with the provider, they can always do it. So they always have the opportunity to do that, discuss it with their clinicians. Next, please. And so these are the social needs screening areas that we are asking questions about. And the household screening domains is for pediatrics. So we look at these from for children and under 18. So these are the ones. And the one with asterisks are all mandates. These are the government mandates and different mandates that we are obligated. The health plan has its own mandates in order to be able to get all these data that is needed. So we are asking all these questions as well, because of some of it is related to mandate, some of it is health equity, some of it is quality of care. So everything is overarching and collaborative. Next, please. So we used to have a workflow where when we got the positive social drivers of health, the expectation was a clinician would have a direct integration will link to our Neighborly, which is a platform that is our community-based organizations are all on that integrated platform. So we would go and put in a referral, but we actually now very recently are piloting 3 different clinics where we have created a social needs resource hub, and we have put in CHAs, which is community health assessment workers and associates, who get a referral directly when the patient answers it, and if they're agreeable to seek the help, they get a referral right at the back end. So it bypasses the clinician, and it just goes straight into the clinical the community health associates, who will put in the referral, and everything that is done is now recorded within Epic. So there is clarity of role, and we're also looking at how are we using this information to close care gaps. So those are things. And the other important thing that we have developed and integrated is that if there is a positive social needs screen, there's automatically a banner that goes on the chart, and that actually enables us to identify that this patient needs X amount of help in these areas. And also on the after visit summary, there is a link to the Neighborly platform, which is the large platform that has all the community-based organizations, which we call CBOs, housed, that are there to help our patients with their healthcare needs. Next, please. So the response to positive screenings, we will put in a referral, or the CHAs will put in a referral. We can launch a Neighborly, which is directly integrated right within Epic. And then also our AMP reports, which are we call anticipatory management reports. They are the plans that are created for us. Every clinician, when they open a chart, will see them. It comes out as a pop-up window, and we put in reminders in that as well. And everything is now documented in Epic for us to be able to understand what the screenings are and what is being done for it. Next, please. So this is our Neighborly platform. It is web-based right now, and there was an app as well that may have come, or it's in the process of being developed. And there are, in the state of Pennsylvania, we have 11,000 plus program, and in the entire United States, there are 600,000 different programs in various categories of assistance for our patients, and they connect with these local community-based organizations as well to be able to provide the care that is needed and help patients, because as I explained in the beginning, that these drivers of health have a tremendous amount of contribution on the health outcomes. It makes a huge difference. And we could use this Neighborly site to be able to put in referrals for ourselves and look and track what's happening with our patients. Next, please. So collecting the data, using the Neighborly platform, and then we anticipate that more of our clinicians will look at the banner, look at the needs, and also use there's something called as Z codes, and these Z codes are the social needs that we would love our clinicians to be able to make sure that it is put on a problem list, because that itself is striking for anybody looking, especially in care teams. And it also at some point of time will be used for defining the case mix index, which may have reimbursement related financial implications for the system. So that's what, and then that longitudinal health record, the idea of having those stratifications on a patient chart is very helpful for us as clinicians to be able to understand what else do we need to do besides prescribing a medication for our patients that will help to improve care outcomes. Next, please. So analyzing our social data, that something like, just take a guess, like what are the top 3 social needs that you think our adult patients are needing? Next, please. So it's employment, food, and transportation. But the reality is that these are the most reported social needs, but does it mean that that's what they're asking us to help them with? Next. So when they report social needs, the top are the employment, food, and transportation. But what are they needing help with when they ask us is the completely different. Next, please. So the top resource requests are housing, utilities, and food, and it's seasonal. When especially in the winter times, we see a lot of people who have difficulty paying for heat. So we see those kind of social needs as well, and then we have to adapt accordingly to ensure that we are proactive in helping our patients accordingly. Next, please. So about 20% of our patients have expressed that they have some social needs that need help with. And our GHP family, which has our access patients, so which are Medicaid patients, there is almost 33% of our patients have social needs. And we try our best to ensure that we take good care of our patients and connect them with our CBOs. Next, please. So this was a case study that we can actually skip now, but I mean, this is something that I wanted to talk about as a veteran patient who would come to us and was on medications and realized that his lost his wife, but lives alone. But if he did not have the social needs survey, we would not know that the patient has these social needs, because people typically don't get into these details, unfortunately, because of the lack of time. So having these known social needs, we were able to connect our patient with the right community-based organizations, and we were able to improve our care for our patient. Next, please. Next, please. I wanted to go over something related to our fresh food pharmacy, Heather.
Here we go.
Yeah. So this is a very good initiative that was started at Geisinger. We looked at our diabetic patients and uncontrolled diabetics with the hemoglobin A1C greater than 8. Besides prescribing the medications, we realized that patients, especially who have this social needs and who are not able to manage a good healthy diet, you can give them any number of medication. Compliance would be an issue sometimes, right? But also it's food as medicine. So we created something which is called as a fresh food pharmacy, and we identify these patients who have needs and are uncontrolled diabetics, and we actually provide food not for the patient itself, but for the entire family. 10 meals a week, and that really has helped them. We have 3 brick and mortar locations and also 2 satellite locations outside our area. But the patients that we have helped have shown significant improvement. There's a significant amount of A1C, hemoglobin A1C reduction, literally over 2%. With no medication will do that. Trust me on that. Not just will lose the lower 2.5% of hemoglobin A1C. There is more because of these. There's better compliance with IB exams, food exams, and blood pressure goals. Using the right amount of food. And how does it help us? Besides improving care as a health plan, and why are they making these investments? It does help them. So there's a digital mobile app for this fresh food pharmacy that we have created, and we have seen a 20% reduction in admissions, which is huge. Imagine when you go to value-based care, where the payments are it's not productivity based. It's not based on every interaction. It's value-based care is a risk model that we take. So by using this fresh food pharmacy, there's a significant reduction in the number of emergency room visits unnecessary, and per member there's almost like a $10,000 savings. And just based on our enrollment, the health plan estimated like savings of 4.7 million, giving food and reducing complications, improving compliance, and improving healthcare outcomes. So food as a medicine is a covered benefit for us, and it is a worthwhile investment for us to be able to do for our patients. Next, please. So these are the other areas that we have worked on. Just food. We also help our patients who have access issues to provide transportation and ensure that we are invested in the community. So there is some funding as well for GED to people who have not been able to graduate, so that they have some ability to have basic education, because as educated parents take better care of their children, as well as going downstream. So it does help. So we are focused on these social needs programs to improve care for our patients, and then we measure them on how well we are doing, and then we pivot accordingly and put in more resources based on where is needed. So we have a whole analytics hub that looks at and tracks a lot of different foundational initiatives to be able to have a CQI kind of impact on delivering care moving forward. So I know it was a lot. We tried our best to give you guys a feel for really what is happening as a system in the being part of a care system, being part of delivering care, looking at health equity in overall as in the health plan, as well as with the med school and education along with patient care. Overall, the collaborative is very impactful, but we need the right executives with the right mindset to be able to put the resources and ensure that health equity is at the center of fulcrum of delivering care to our patients. So I know we went a little longer than we should have, but we're open to questions, and we can obviously stay back a few minutes if needed as well. Thank you for your attention. I appreciate it.
Thank you all so much for the amazing talk. If anyone has questions, they can, I guess, unmute or type in the chat.
Okay. Hi, I had a quick question. So thanks for the cool talk. I feel like this is super informative. So I guess I was just curious, so like what type of are you guys actively like measuring like the impacts on care like
Yes.
live, I guess, and like if so, like what's like a quote success, I guess, for like health equity, or is that a silly question?
No, it's not a silly question. It's a very valuable question, because when you put in programs, right, you want to make sure that it has an impact, it going down. So the fresh food pharmacy that I explained is a great example. Putting a Spanish language navigator has improved colon cancer screening for our patients who have Spanish as the main language. Connection with them is important. Ensuring access by providing rights to the patients has shown to have more patients coming into the clinic. You don't want people with cough or a cold going to the emergency room, right? You want to make sure that they come to the clinic or our urgent care. So connecting with these patients, creating a relationship with these patients has improved the overall care. So we don't want our emergency rooms to have patients sitting over there for 8 hours for a cold, right? I mean, that you don't need all those kind of things. So delivering the right kind of care to the right substrate of patients is what has helped us understanding those social needs. Yeah,
Hi, I had a question.
sure.
It was about in the first few slides, at one point you guys showed that about 30%, like an individual's health outcomes relied about 30% on their social status, not yeah, social situation. And I was wondering how
Lifestyle. Those
lifestyle.
like life. Yeah, yeah.
Yeah, and I was wondering how if you knew like where this number came from and how they quantify this number specifically. I feel like it's a very I was wondering how you would be able to like quantify and
Yeah,
evaluate
so
that.
So a lot of it is based on experts, epidemiology, studies, peer-reviewed journals, and who look at causal effects of different areas, as well as if you look at in terms of etiology of what is causing problems. So all these factors, there are many studies that are there. If you look at the literature review, you will find them. And so, as I said, don't go by absolute numbers. They're basically based on consensus of epidemiologists and consensus of clinical outcomes data and impact. Like if, for example, like when we are giving real healthy food to our patients, it's basically lifestyle changes. They could go and eat burgers, and they could go and eat fries, and they could go, their diabetes is never going to be under control, right? But that by itself, so that is an intervention. That's not a medication intervention. It's a lifestyle intervention that shows such a significant impact on what the care delivery is going to be and on what the outcome is going to be. We have reduced unnecessary blindness that's caused by diabetes significantly, amputations significantly, heart attacks and strokes by improving diabetes using non-traditional interventions like fresh food pharmacy, nutritional counseling, etc. Weight loss, they make a huge impact and difference.
Thank you.
And one thing that I'm hugely a proponent when I teach my med students is to avoid using the term compliance and non-compliance a lot, because sometimes when we label our patients as non-compliant, and then that kind of creates unnecessary bias, because you got to realize like literally what all goes into why somebody not following care. Like I'll give you an example. I was a R1, a resident 20 plus years ago. I look dated, but anyway, so when I was doing my residency, I was seeing a patient who was a diabetic, and I could not control the hemoglobin A1C, and I was like, okay, let's increase the insulin, let's increase the insulin. Every time, every 2 weeks, I was seeing the patient, and I was making medication changes, and nothing was working until one of our social workers went to their patient's house. He did not even have a refrigerator, never filled insulin. So like I stupidly was increasing doses. The patient had never even was not even taking insulin because he did not even have a refrigerator to keep insulin. So some things like this that are out of our radar, we don't see it unless until we really go and look deep into it.
Thank you. And, appreciate that story that really, I think, contextualizes the messages from this great talk. So both of you, really want to thank you for your time today and insights. And I see that we are just over the hour here. So I think we'll wrap up, and, want to thank you again for sharing this with us.
Thank you.
Absolutely. Thank you for joining, and I hope you have a great afternoon.